Are you ready for the challenge? When you jump into this journey called dermoscopy, your zone of uncertainty is this wide. There'll be one end of the spectrum where you feel quite happy to diagnose a simple wart or skin tag perhaps. At the other end, there's a rapidly growing, eroding, bleeding, fungating, ulcerated nodule would be a no-brainer to refer on. It's this zone of uncertainty where primary care dermoscopy makes all the difference. With time and experience, this zone of uncertainty will shrink for you, although it never fully disappears. The purpose of my training quizzes is to exercise your brain. Grab a pen and paper. I'm going to present 4 of my patients and then ask you questions to answer. Assume the patient doesn't have a history of skin cancer unless I tell you. And after presenting them, we'll then go through each with my answers. You may disagree with me. That's fine. That's what the comment sections below this video is for. Ready? A 76-year-old gentleman comes to see you having noticed this new mole for the first time when showering 7 days ago. There's no symptoms. It's around 15 millimeters in diameter. Here's the dermoscopy. What's your diagnosis? How certain are you? What clues helped you reach your conclusion? How would you manage him? This 72-year-old gentleman comes to see you, having noticed this dark black papule on his lower shin. He's not sure how long it's been there, but in the 3 weeks it's taken him to get to see you, it hasn't changed. It's a papule that feels firm, but not hard to the touch and has no symptoms. What's your diagnosis? How certain are you? What clues helped you reach your conclusion? How would you manage him? An 86-year-old gentleman presents with a 3-month history of this slowly growing, asymptomatic, hard pink papule on his nose. What is your diagnosis? How certain are you? What clues helped you reach your conclusion? How would you manage him? An 83-year-old gentleman came to you, his wife having noticed a new change on his lower back skin recently. They weren't sure how long it had been there. There were no symptoms. What is your diagnosis? How certain are you? What clues helped you reach your conclusion? How would you manage him? Patients call anything on their skin that is brown or dark coloured a mole. Note the well-demarcated edge all the way around, but a little variation in colour. For the novice, this variation in colour would trigger a cancer care pathway 2-week wait referral just to be sure exclude a melanoma. The dermoscopy is reassuring, however. Milia are present on the polarised light setting. They flash up bright on the non-polarised setting, giving the stars in the night sky appearance. You can find milia occasionally in other skin lesions. This number and appearance suggest a seborrheic keratosis. What do you make of this pattern? Is this a network pattern of a melanocytic lesion or the fissures and ridges of a seborrheic keratosis? At the top, it's much more a cerebriform pattern with fat fingers intertwined. The well-demarcated edge also is typical for a SEB-K, whereas in a nevus or mole, the network pattern usually fades out at the edges. Learning to differentiate the network of a mole and the fissures and ridges pattern of a SEB-K is a key dermoscopic skill you will need to learn. Are there any other clues here? Well, look at this. On the non-polarized setting, which views the upper epidermis better, we have a few crypts, although not many. This colour here used to worry me, as you'll often hear about a blue-white veil seen in melanomas. This purple colour is common in the thickened acanthotic part of a seborrheic keratosis and isn't a blue-white veil. There's no keratin scales anywhere I can see. Putting the clues together, this is a seborrheic keratosis. And if you'd called it an acanthotic seborrheic keratosis, you get a pat on the back. How certain were you that this was a seborrheic keratosis? If it isn't 100%, then perhaps you need to watch my video again. It's not uncommon for patients to be unsure how long a skin lesion has been present. This small papule looks dark, almost black. As it's new, could this be a nodular melanoma? Let's see if dermoscopy can reassure us otherwise. Is there any brown? No. Are there any blood vessels traversing its surface? No. It's made up of red, blue and purple globules throughout. These are lacunes, and this is a capillary hemangioma, a hamartoma of skin capillaries, and is benign. If you said an angiokeratoma, I'd be even more impressed. This variation in colour in size of the lacunas is typical for one of those. Don't let this blue-white stroma put you off, because there's no melanocytic criteria here, and it's not a nevus or, thankfully, a melanoma. Leave it well alone and reassure your patient strongly. If you weren't 100% sure this was an angioma, then perhaps revisit this video. What did you make of this pink papule on this gentleman's nose? I trust his history of it slowly growing over 3 months, because patients don't usually miss something as plain as the nose on their faces. A few possibilities came to mind. Is it a wart, a BCC, or even an SCC? The surface wasn't rough or scaly, so just from its clinical appearance, a BCC was top of my list. Will the dermoscopy confirm this? This large white structureless area is very prominent, common in keratinizing lesions such as warts or an SCC. But note the white blotches and streaks that flash up on polarized light this time. This makes them shiny white structures found in around 50% of BCCs, but not in warts or squamous cell cancers. This white area may be a May globule, and these are seen under both polarized and non-polarized light, but if so, there's only one. May stands for multiple aggregated yellow-white globules, and one isn't multiple, so I'm not so sure. Are these vessels arborizing, or is it a polymorphic pattern, do you think? It's not a wart. Dermoscopy has nothing to offer that diagnosis. The clinical appearance, lack of scale, and shiny white structures made BCC the most likely. However, from a GP point of view, it doesn't matter. SCC or BCC, in this location it warrants a 2-week wait cancer care pathway referral. And on removal, it was a nodular BCC. When I first saw this skin lesion, I did a double take. It's different colours, an odd shape. Is it a melanoma? But as you get closer, you realise, I hope, that we have 2 different skin lesions here touching. It's a collision lesion. The right half has a stuck-on appearance, fissures and ridges, a thick mantle of yellow-brown keratin. It has a well-demarcated edge and even a few milia and hairpin vessels with a white halo around. It's a typical hyperkeratotic SEB-K, best left alone. What about the other half? Note the multiple erosions, the homogeneous pink background. This is most likely crust from the erosions rather than keratin scale. Short, shiny white structures litter the surface under polarized light. This is a BCC, and everything so far suggests a superficial one at that. Check carefully for signs of any nodular elements, because dermal invasion means you need formal excision to remove it. I wasn't convinced this was a blue-grey globule, and it's macular, so I diagnosed a superficial BCC attached to a hyperkeratotic SEB-K. How would you manage this? This is a low-risk site and has probably been there for many months. A routine referral to secondary care would be fine. If you do excisions, as this is a low-risk location, using a 5mm margin would sort the problem out. After discussing options with my patient, he opted for topical treatment, imiquimod being chosen, and it has responded very well and resolved nicely using that. So how did you do? If you did poorly, then perhaps watch the video suggested, which should help you develop your basic knowledge. If you pass with flying colours, then great! Now get back to helping your patients for real. Remember, your best teachers are your patients, but only if you choose to listen to them. Training a primary care dermoscopist for every general practice.